Thank you, Chairpersons. Thank you, Dr. Parag Bhai and the entire team at IDCM for inviting me for this talk. So guidelines, right from my study days, we are not very much attracted to this topic, used to be boring. So for this kind of talk, I am selecting only important points to discuss. This is actually a very exhaustive document which has been published in year 2023. Nonetheless, it is very important in our day-to-day practice, and I will try to cover it in the 10 commandments way. So who are the patients of chronic stable angina? So crowd here does not need introduction about the symptom profile. All those patients with stable angina symptoms which are exertional and not progressing in recent past, let us say in last 3 to 6 months at least. Those with evidence of coronary vasospasm or microvascular angina. Those patients who are diagnosed with chronic coronary artery disease based solely on results of screening study, that is treadmill, stress echo, CT angio, myocardial perfusion imaging. Those patients who are discharged after acute coronary syndrome, angioplasty or bypass, or after recovering from any acute cardiovascular event that includes even stroke and peripheral vascular disease. And all those patients who have been diagnosed with systolic dysfunction and have low LV ejection fraction. So these are the groups of patients who will be classified under chronic stable coronary artery disease. The term is different than chronic stable angina because angina tends to restrict ourselves to only symptoms of angina, whereas CAD will encompass a wider group of patients and it will include all of them. So why it is important to discuss about guidelines and guideline-directed management in all these patients. If we see the global age-adjusted prevalence of chronic coronary disease per 1 lakh, then this is the data which is published in the guidelines which are recently published in 2023. And for India, the South Asian group, it shows about 3.3 to 5.1%. And that number is relatively higher than what is there in US, relatively higher than what is there in Europe. So if Western countries are coming up with guidelines mainly focusing for cost effectiveness, definitely we as Indians, South Asians, definitely must look into the cost effectiveness and appropriateness of the therapy. And that's the reason for importance of this guidelines. So what are the goals of treatment in a patient who has chronic coronary artery disease? First and foremost is improvement of symptoms and functional limitations. Second most important is incidence of death, non-fatal MI, and lastly to retard the progression of atherosclerosis. So if we know that what is the mortality rate of acute ST elevation MI in the current era, maybe close to 5%. The chronic coronary artery disease or chronic coronary stable syndromes, all of them will have a variable mortality, yearly mortality rate between 1 to 3%. So this group of patients are at relatively low risk of death. So whatever you are treating them, either with medications or with intervention in the form of angioplasty or revascularization with bypass, or for that matter anything, it is very difficult to show a mortality benefit of any given treatment modality. And therefore it is important that first and foremost, you must answer what are your goals of treatment, and the first and foremost is to have improvement in the symptoms. After that comes other aspects, reduction in incidence of death, non-fatal MI, and atherosclerosis. So just keep in mind these 3 clinical profile. We will come to it. We don't need answers as of now, but let us see at the end of the talk what we feel about it. A 45-year-old male who is asymptomatic, active lifestyle, hypertension, normal looking LDL 106, but has a CT calcium score of 360. What would you do? So asymptomatic, relatively high CT calcium score, hypertension, asymptomatic, what would you do? Another patient is 68-year-old female, diabetic, hypertensive, obesity, osteoarthritis, knee, dyspneic, LBB on ECG, EF 45%. What will you do? And third patient, 30-year-old female, normotensive, non-diabetic, dyspnea, high TG, low HDL, hypothyroid, LBBB, EF 30, what would you do? Should all these 3 patients receive angiogram or not? Second and third should receive. What should the first one receive? Right. Any other opinions? Like Dr. Paragnana is suggesting that patient B and patient C should receive angiogram, and patient A can be left alone, and we should do with ASCVD risk score calculation and then decide what to do. Yes. Yes. So ecosprin, yes. What else? Statins. 106, do we want to look into anything else? Like, what dose of statin would you give?
You look at other risk factors.
Like, this is all we have. All positive things are noted here. Is asymptomatic right now, physically active lifestyle, non-sedentary, non-diabetic, hypertension, LDL 106. Yes. So most important is that you will need to cut down this so-called normal LDL by 50% at least, because your CT calcium score is high, and this patient will require at least moderate dose of statin to bring down levels to 50%, that is close to 50, right? So this patient would definitely require aspirin and statin, and control of hypertension, of course. So I think my discussion is over actually. The crowd will not need more discussion. But nonetheless, we'll go through certain things which are there. So we'll go through 10 points which are important messages. So in the newer guidelines, as far as evaluation, diagnosis and risk stratification is concerned, there is increasing emphasis on stress imaging as a modality of first choice over treadmill test. Like, commonly treadmill test is the first investigation of choice, but as per the guidelines, what they say is that either perform PET or SPECT, either perform stress cardiac MRI or perform dobutamine stress echo, which are rated much higher because they are going to tell you which region in the particular vascular territory the ischemia is happening, and it is likely to be more specific. And that's why your decision making becomes simpler. The chance of false positives go down, which can happen with treadmill testing. And that's why exercise treadmill testing is rated lower than these kind of modalities. CT coronary angiography is restricted to patients for assessing anatomy in high-risk individuals. Again, ASCVD risk score calculation will help you. And all those patients where follow-up angiogram is required in, let us say, in post-CABG or post-angioplasty patients, especially if the vessels are more than 3 millimeter in proximal vessels. If the stent has been in a distal circulation, then CT coronary angio is not supposed to be as good. So it is having a restricted indications for assessment. Where does the invasive coronary angiography fall? Clearly, if you have progression of symptoms and functional class while on guideline-directed medical therapy, and where the goal is to improve symptoms with future revascularization, then only one should consider invasive angiogram as per the guidelines. If the patient is having a stable functional class without any progression, it does not need. And second most important indication is for diagnostic purpose in patient with new onset systolic dysfunction. If patient has none, like does not have LV dysfunction, does not have heart failure, and his patient NYHA class is stable on maximum medical therapy, these patients routinely do not need coronary angiography. So for the risk stratification, we should be falling back on clinical parameters, which are the patient subgroups where we should be more alert, or our threshold for considering invasive workup should be low. So what are those patients? So obese, prior MI, prior PCI, prior CABG, heart failure, atrial fibrillation, diabetes, dyslipidemia and chronic kidney disease. Clinically, these are the groups of patients where your threshold for invasive workup should be little lower, because these are the groups of patients where the mortality, even with chronic coronary artery disease, is going to be 3% or in excess of it. Another important factor is high calcium score, which you find on CT. High calcium score alone on CT is of a lesser value, but when you supplement it with functional imaging, mainly in the form of either dobutamine stress echo or stress myocardial perfusion imaging, that will increase its utility as far as future course of action is concerned, whether we need to treat that with a revascularization strategy or not. Based on only CT coronary calcium scoring, one should not be considering revascularization as a mode of therapy. Document that these lesions or so-called high calcium burden translates into significant myocardial ischemia, then only one should consider revascularization. Otherwise, as we discussed in the first case, aspirin statin is the mainstay of treatment. Second, there is increasing emphasis on non-pharmacological therapy. That means healthy dietary habits and exercise. And cardiac rehabilitation is concerned, it is given a lot of importance, because as we know that unless we include these aspects of management patient's profile, patients are not going to be free from recurrent events in future. Medicines alone are not likely to make them stable throughout their life. Third important message is moderate to high dose statin. If we see commonly, our commonest prescription in patients who are stable is ecosprin AV. And what is the dose? We give 75 by 10 or 75 by 20 milligram. And we forget about that patient because he's having stable, having least amount of symptoms. But if you keep checking on the levels of lipid profile serially, you would come to know that those lipid levels have not come down drastically, because we want a 50% reduction from the baseline, number one. And after doing that, the second important part is whether those levels have gone below 70 milligram per deciliter or not. And definitely, if you start looking into it, your 10 or 20 milligram dose is unlikely to result into that degree of reduction. So we should go away from those 10 and 20 milligram of atorvastatin. You need at least moderate doses of atorvastatin, that is at least 40 of atorvastatin, at least 20 of rosuvastatin, and higher if required for achieving that aggressive lipid lowering in so-called stable looking patients. Adjunctive drugs like ezetimibe in combination therapy with lower dose statin if the patients are statin intolerant, bempedoic acid if patients if they are intolerant, and reserve PCSK9 inhibitors including monoclonal antibody therapy for patients who are having very high risk, those who are having familial hyperlipidemia and those who have recurrent CV events. Because most important aspect is cost effectiveness. As of now, even American society is contemplating this, that these drugs are too costly for the routine management to be included in the routine management of patients with dyslipidemia. So they should be still considered as reserve drugs, and the benefit by using of these drugs is still accumulating. Data are there for maybe 5 years, 6 years. Data is still accumulating. So we should stick to statin and ezetimibe, and probably it will take care of more than 95% of patients who have dyslipidemia. The PCSK9 probably is reserved for maybe less than 5% of patients. So all these very high risk of future ASCVD events, they are more or less same what we have already discussed. And all these patients definitely should have LDL reduction 50% of baseline or less than 70 milligram per deciliter. So this I think we already discussed. We'll not go into this chart. I think it is a repetition of what we have said. About SGLT2 inhibitors and GLP-1 receptor agonists in patients with chronic coronary artery disease. So two important aspects. Those patients who have diabetes, irrespective of LV dysfunction, should be on SGLT2 inhibitors or GLP-1 agonist drugs, because they have been shown to have proven cardiovascular benefit and future reduction in the risk of MACE. And if a patient has heart failure with ejection fraction less than 40%, irrespective of diabetic status, should receive these two drugs, SGLT2 and GLP-1 receptor agonists. Number 5, what is the recommendation of beta blockers? Again, if beta blockers are first-line drug for symptom relief, and they should always be included in patients with chronic coronary artery disease. But long-term beta blocker therapy is not recommended. They said if the patient does not have MI in past 1 year, if LV ejection fraction is good, then long-term beta blocker does not translate into meaningful benefit. So if you have low EF and if the patient is symptomatic, then use it. Otherwise, in these absence of these factors does not mandate long-term beta blocker therapy. Same way ACE inhibitors, if patient has LV dysfunction, EF less than 40, hypertension, diabetes, CKD, ACE inhibitor ARBs are first-line drugs, must be used. But if the patient does not fall into these categories, they are not likely to have their incremental benefit because the overall risk profile is predicts that they are at a low risk. Antiplatelets, I think in the next talk, they are always going to be discussed, but emphasis is on shorter duration of dual antiplatelet therapy. Once the patient has undergone angioplasty, does not mean that all patients will receive lifetime dual antiplatelet, which is conventionally being understood by so many practitioners. So minimum 6 months of dual antiplatelet therapy is enough. Beyond that, one should justify whether this patient needs dual therapy or not. This mind well, we are talking about chronic coronary artery disease patients. We are not talking of ACS non-STEMI patients, but stable patients undergoing angioplasty should not receive DAPT more than 6 months. So I think this chart will be discussed again in the next talk. 7th, about coronary revascularization. One should always answer the question, why revascularization with angioplasty or bypass one is selecting. So it should be to improve symptoms beyond medical therapy, and second is to improve survival in all those patients who have low ejection fraction. And angiographic syntax score, it helps in decision making. If you have high syntax score, more than 33, diabetic, multivessel disease, left main disease, LV dysfunction, definitely CABG is the first choice. High risk, complex anatomy, CABG is the answer. Isolated left main disease, non-diabetic, PCI may be equivalent for improvement of survival. It is given class 2A indication. All those patients who are low risk, relatively low risk, despite having multivessel disease with a low syntax score, their PCI and angioplasty and CABG, both are considered optimum for symptom relief and prevention of MACE. So all triple vessel disease means bypass, that notion one should get away with. There is further risk stratification based on clinical profile, LV dysfunction, and syntax scoring that can aid and help us in finding out which modality is right for a given patient. If the patient is at a very high risk for surgery, all those triple vessel disease also may be considered for angioplasty for improvement of symptoms and reducing the risk of MACE. But most important aspect is that PCI should be able to provide revascularization which is equivalent to bypass. If it is not so, angioplasties are definitely going to be inferior. And second, one has to understand that the whole benefit of CABG lies in grafting Lima artery to LAD. If patient does not get Lima graft, then definitely CABG is much inferior to currently available drug-eluting stent angioplasty, right? Eighth, use of non-prescription or dietary supplements. They are like fish oil or omega-3 fatty acids. They are not recommended in patients with chronic coronary disease, given the lack of benefit in reducing cardiovascular events. These are all other don'ts. So important is that consumption of alcohol. Patient with chronic coronary artery disease should not be advised to consume alcohol for the purpose of CV protection. Second, addition of colchicine for secondary prevention. Again, that is given class 2B indication. It's not a preferred mode of therapy. Third, ECP, external counterpulsation, enhanced external counterpulsation. Again, it is reserved for patients who have refractory angina and no other revascularization options in the form of medical therapy, angioplasty, or bypass. If they are having bad angina, then only it should be considered for ECP. That's not a first-line therapy to be recommended for people who have not been tried with these three modalities, that is medical therapy, CABG, or angioplasty. Lastly, ivabradine as an add-on as an anti-anginal, not recommended. And lastly, females, post-menopausal female with chronic coronary artery disease, they should not be receiving hormone replacement therapy because that does not translate into, again, reduction in the MACE or mortality. And there is increased risk of venous thromboembolism. So I think these are all don'ts as far as these modalities, different modalities in management are concerned. With improved overall survival, more patients of chronic coronary artery disease present with comorbidities and multi-system affection, and therefore immunization is recommended to prevent infections which lead to morbidity and mortality. So annual influenza vaccination is recommended. Pneumococcal vaccination again is recommended. And the last, routine periodic anatomic or ischemia testing without change in clinical or functional status is not recommended. Let us say patient has a stable clinical profile. How frequently you should follow them up? Do you ask them to get angiogram done every 6 months or every 1 year? No. If this functional status class does not change, they don't need to be followed up before a year. So routine treadmill testing, routine echocardiograms, if their functional status does not change, you need not do it. So I think that sums up my talk about guidelines in chronic stable angina. Thank you.